Okay. Good morning. My name is Darshan Mehta. I'm the Associate Director of Education for the Osher Center for Integrative Medicine here at Brigham. And it's really my honor to be co-leading these Grand Rounds presentations with Helene Langevin. And we are excited to have the Spaulding Rehabilitation Network present to us. Just a quick couple of housekeeping things. One is where a few more people will trickle in. These presentations happen on the first Tuesday of every month, and if you haven't signed up to receive the Osher Center broadcasts or emails, please do so, or you can always access it on our website at oshercenter.org of our future events. At the end of the presentation, I'll tell you about our next presentation as well, which will, I guess just quickly, we do have also Osher Center Research Seminar Series this Thursday from 4 to 5 p.m. We have a fantastic talk on acupuncture and its role in postmenopausal symptoms. So without further ado, I would like to introduce Rick Leskowitz, who's the director of the Spaulding Center's Integrative Medicine Task Force, and he will introduce the speakers.
Well, thank you, Darshan, and everybody else on the team for inviting us, Ellen and Veronica, and I don't see Atara, but you guys have done a great job in pulling this forum together because it's so important to integrative medicine in Boston. We really appreciate this opportunity because we've been doing some integrative work in the Spaulding system for 25 plus years, and it's a great opportunity to tell you a little bit about what we're doing. Presenters will be myself. Eve Kennedy Spaien is the clinical supervisor in the pain program and outpatient integrative medicine supervisor. Jennifer Jackson is a senior clinical specialist in physical therapy. Cathys is our guest patient, and we really appreciate your willingness to share your experience with us. And Ariana Vora is a physiatrist who will be our discussant. The format is pretty standard. I'd like to give a little bit of background about Spaulding's involvement in integrative medicine, and then we'll talk about our pain program and the philosophy and the structure. I'll do the case presentation, and then each of us will talk about our clinical involvement and interventions. We'll hear from Kathy, we'll hear from Dr. Vora, and then we'll open up to question and answers. So Spaulding has a history in integrative medicine dating back to the first OAM grant, gigantic grant of $30,000 to study homeopathy and head injury. It was a big triumph because Spaulding was not a research hospital at that time, but it was a big bind for our hospital director because how could he brag about homeopathy as a grant, because back then you didn't mention those kind of words. The first Harvard-sponsored continuing education course in a partner's hospital actually took place in Spaulding. Back in '98 was the first one. This is the second one. Complementary and alternative medicine and rehabilitation. We had keynote speakers, Herb Benson, David Eisenberg, and John Kabat-Zinn, and it was great, and it was really laid the foundation for the work that we did over the following years. We've had community events with well-known speakers talking about their experience with rehabilitation. Ram Dass spoke about what the spiritual meaning of a stroke and recovery was, and it was inspiring. I know some of you were actually there. We had Tricia Miley, better known as the Central Park Jogger, talk about how she recovered from her significant brain injury by using a form of mindfulness that she actually developed on her own before partnering up with John Kabat-Zinn. And actually her first public speaking engagement as the Central Park Jogger was at Spaulding. We've hosted conferences, and in particular I'm highlighting this one because the theme, caring for the caregiver, is so important in integrative medicine for our benefit, and also because it's a common theme among our patients, especially in chronic pain, where wanting to help others so much leads to the potential for burnout. And you'll see how that played out in today's presentation. So let me say something just briefly about rehabilitation and integrative medicine. In a nutshell, they're made for each other. Integrative medicine is multidimensional, body, mind, spirit, And rehab medicine is as well, that the team approach is always present. On inpatient, you'll have PT, OT, nurses, speech therapists, behavioral health, as well as the doctor. And so the team communication is important, and teamwork is the norm. And also because we don't cure, amputees don't grow their limbs back, for example, so we emphasize function and quality of life rather than symptom removal, and that opens up to the broader kind of internal domain. In the Spaulding network of 3 inpatient hospitals and several dozen outpatient clinics, we have a wide array of integrative medicine providers, and what's unique about, I think, about our program is that the providers have conventional clinical degrees as well as their additional expertise. And so it's not that we do our treatment and then call in an integrative medicine provider. Integrative medicine is integrated in to our clinical care, and I think you'll see that as we describe what we're doing. So just a quick philosophical look at pain and how integrative medicine views it. In allopathic medicine, pain is the enemy. It's a target symptom. We aim our therapeutic armamentarium at it. We have, just think of the kinds of medicines that we use: antibiotics, antidepressants, anticonvulsants. Everything is against. There's nothing pro, unless you count Prozac. But even that is not quite the same thing. So suppressing symptoms is one way of going about it. But in integrative medicine, we believe that symptoms have meaning, have important feedback if we only listen. And so how can the patient's life be rebalanced based on what we learn from their symptoms? And thoughts, emotions, even subtle energies are part of that whole picture. Chronic pain, as you know, is a very significant cause of disability across the spectrum in America, a financial cost and emotional cost as well. We define it as a behavioral syndrome because when pain persists, it's not so much the peripheral nociception that matters, it's how it's processed centrally. And there's a lot of neuropsychiatric research about the mechanism of central sensitization. We don't need to go into that here, but just to know that the biopsychosocial model has been helpful for many years, and it's an ideal format for integrative medicine. As you can see from the chart here, pain complaints are the primary reason that people pursue complementary therapies. So that's a brief overview of Spaulding and what we've done. I'm going to turn the mic over to Eve now, who will explain the philosophy and the principles of our functional restoration program and set the stage for our presentation of the case and then discussion of our individual treatment plans. And then we'll hear from Kathy and others.
Yeah. Good morning. It's good to see everybody here. So when it gets to a chronic pain situation, that's really when we need to look at something more intensive than the traditional therapies. In chronic pain, it's really affecting all aspects of people's lives. So our functional restoration program looks at the medical piece, the psychological piece, the physical piece, the functional piece. It pulls it all together, and it's immersed in a cognitive behavioral framework where we're all speaking the same language. And the main goal is really what we all want, to be able to get back to doing the meaningful things in our life. So it takes a village, or to run a pain program, it takes a team. And as you can see from this, we have a very large team. All of our patients are evaluated by the entire team, so we can really get the whole picture. They may not see everyone on this list, but everyone does see the physician, the occupational therapist, the physical therapist, and the behavioral health. And we're really focused on self-management. It's that we're going to empower the patient to use their own healing abilities and their own skills to be able to manage the pain versus doing something to them. We're very focused on function, getting back to doing what's important versus measuring pain levels. And we have patient care conferences. There's lots of communication. As a matter of fact, as OSHA was starting up, one of the things they did was they came and observed the program at work and how our patient care conferences were working and the team was integrated. There's tons of evidence as far as the benefit of FRP for treatment. And these are just a couple of studies here, but it's not only effective for the patient, which is the most important, But unfortunately, we all know that the insurance companies are looking at the bottom line, and it's very cost effective. And we see this in our outcomes, which I'm going to be talking about a little more later. So these are just our basic admission criteria, people that are appropriate for the program. They need to be motivated to make change. And it doesn't have to be the last thing they try. The thing I hear more than anything from everybody is, why didn't somebody tell me about this sooner? So that's one of the pieces that we really want people to know, is that there are other options. It's a multi-tiered program, so it's not one size fits all, because people are not one size fits all. We evaluate each individual and really look at what they need. So they could do up to our full day program, which is 4 hours a day, or they could do the individual pieces of the program that are most appropriate for them. If they did the whole program, this is what the typical day would look like. You can see how some of the integrative medicine pieces, the relaxation, the Tai Chi, the yoga, are combined in with learning anatomy, doing exercise. Everything is pulled together. And so now I'm going to hand it back to Rick, who can explain some of Cathys' history.
So this is just a nutshell summary of some of the important points. Significantly, there were some family background aspects that are important to mention. That she grew up in Alabama, and her family had to deal with the ongoing strain of a sister with bipolar disorder and substance abuse, and it was tremendous stressor ongoing. And Cathys recognizes that her role was to be, in a way, the family therapist, because she tended to absorb the emotions from other people. And that's a common factor, and it helps to be empathic, but the balance point is something that has marked a lot of her development, so I mentioned it here. In high school, she was active in activities like student government, and she had a bachelor's in fashion marketing, but went on to develop a highly successful career as a media relations specialist nationally for some very prominent organizations. What's interesting about her situation compared to our normal, quote-unquote, chronic pain patient is that she has a strong background in mind-body practices like yoga and meditation. It wasn't something completely new. In fact, she had been practicing and teaching for over 20 years. She's been married to for 9 years in a very interesting kind of dynamic of a New Age Southern belle and an Israeli Sabra. So there were some cultural sparks there. And they've been raising 3 stepchildren as well. In terms of the pain history, she has a typical presentation in that there are multiple pain generators, and it's not one simple single diagnosis. So starting back 25 years ago with a mono and diagnosis of chronic fatigue. In the 90s, she had low back pain. With the standard workup, MRI showed minor impingement at the lumbosacral level, and she did respond well to a couple of epidural steroid injections for the radicular symptoms. She had frozen shoulder that seemed to be a separate event that wasn't tied into any particular triggers. Ongoing neck pain and migraine headaches with a myofascial component, and you'll hear about how some of the manual therapies played into that. And then more recently, she was diagnosed with osteoarthritis in the left hip and bursitis in the trochanter. So these are some of the array of generators that contributed, we believe, to the ultimate diagnosis of fibromyalgia a couple of years ago, which followed a period of several years of very intense stress, multiple sources, including the tragic death of her best friend from cancer. And these were combining to overwhelm her system. Some of the ongoing, more standard treatments include fairly gentle array of medications compared to what our typical chronic pain patients are taking. And Cathys mentions that she's very, very sensitive to medication side effects, and so we'll tend to avoid them whenever possible, especially psychotropic medications, because of the sort of the echoes of how psychoactive medicines had a negative impact with her sister. Currently, she's taking migraine medicines, olmatriptan, muscle relaxant, tizanidine, and occasional ibuprofen. A wide array of supplements that she has devised over the years, including omega-3s, antioxidants, and specific minerals and vitamins. Her diet has been modified much to her benefit with the paleo diet and eliminating gluten as well. She does drink some coffee, a couple of cups a day for migraine, but no alcohol, marijuana, other intoxicants. Interestingly, with stress management, she had found that meditation was no longer as effective as it used to be, and her practice had dwindled until starting the program. And she has been in a monthly fibromyalgia support group, which is very helpful. Other more integrative interventions, the most helpful were massage and chiropractic, whereas craniosacral and acupuncture didn't really help the change, didn't help the pain significantly. So let me say a little bit about, now that we know the nutshell about Cathie, let me say a little bit about the behavioral health approach to chronic pain, and then talk about my treatments and Eve's and Jen's, and then we'll tie it all together. It's more educational than anything, to learn about the stress-pain connection and to learn skills that can help people modulate their autonomic nervous system. We do it in a group format, which is extremely powerful. The therapeutic milieu leads to a sense of acceptance, which helps to release the shame that many disabled people, and especially chronic pain patients, feel because they so often hear, "You look fine, what's the problem?" And it creates that sense of something being deeply wrong internally. So there's a healing that goes on at that level that's really important. And I also do individual counseling, as we'll talk about. The cognitive behavioral approach, the main point is that thoughts affect physiology, and the kind of thoughts that people have are under their control. So if they continually telling themselves that something is wrong, something's broken, if I move my arm, it will damage me, those thoughts are damaging directly. And so learning to recognize the connection between thoughts, behaviors, and pain is really important, and then they can learn adaptive coping strategies. My current favorite therapy is called the umbrella of energy psychology. I'm not sure how many of you may have heard of tapping or EFT, but there's a new development of meridian-based psychotherapy that in technical terms you could call exposure desensitization, because the person will think about something that's upsetting, bring up the negative emotion, and then by self-tapping and affirmations, it's very dramatic how it works, and there's a very respectable literature now, especially for post-traumatic stress disorder. So in our clinic we found, for example, that phantom limb pain can respond dramatically to this approach. The bottom line is that it leads to a rapid and sustained reduction in emotional distress levels. So with Cathie, the key element, I think, was coming to the understanding that she deserved time for herself, and she needn't feel guilty about that, having Cathie time. She learned assertive communication regarding her family demands and competing demands for her time and energy, and the cultural demands of, do you just push through something that doesn't feel bad, or is there another way of addressing it? One particular skill involved the concept of energy hygiene, that when you're interacting with other people and they come into your personal space, their energy somehow or other stays with you. We took it as a literal, not just symbolic, but literal, and worked with ways to release other people's presence from your own sphere of influence. And she found that very helpful to sense her own boundaries, that this is my space, and from that space I act. She was also encouraged to continue the activities that have always been so rejuvenating and recharging for her, spending time in nature, gardening, being with animals, etc. So the most important themes were helping her to respect her energetic boundaries and to redefine her responsibilities to herself and to others. So let me turn over the mic to Jen Jackson, who will talk about physical therapy and how that helped to get Cathie moving again.
Okay. I thought this would be a good cartoon to open up for physical therapy. So one of the roles of a physical therapist is to really do a lot of education, especially on self-management. So I don't know if anyone's ever tried this type of massage, but it sounds interesting. Never tried it, but. So with physical therapy and chronic pain, I know all of you probably know a lot about physical therapy. We do a lot of exercise-based, strengthening, stretching, but that's not all we do. We also do a lot of education, especially with clients with chronic pain. Education is key because a lot of people come to me and they've already had a lot of physical therapy prior, and a lot of times they'll say, I don't want to do this because it hurt me. And so I pretty much hear that about 90% of the time. So my role is to try to let them know not all physical therapy is the same, that there are different physical therapy treatment techniques. With the clients with chronic pain, we really have to stress the pacing of the exercise, listening to their body, not pushing through the pain. We also have to make sure they understand the difference between hurt versus harm when they are exercising. What's regular soreness versus injuring themselves. The exercises are based on a graded level of progression. We encourage them to move and not guard, but also to listen to their body. So if movement hurts, then you need to try to figure out a way to move in a better way. Slow and steady and using the breathing is very key. We also add manual therapy if necessary, but it is not the focus. And we also add progressive cardio program. Usually people start just using a couple different machines for 5 or 6 minutes, and we usually try to do a combination of machines because most of the people that are staying in one static position do actually get more guarded and more tense. So we do have a variety of different machines for them, and the goal is to increase it to 30 minutes. Usually they start out with just 6 minutes, but believe it or not, people end up getting up to 30 and 40 minutes by the end of their treatment. In the physical therapy evaluation with Cathie, I noticed a lot of different aspects, especially what was really key with her is she did have a lot of left hip pain as the history was discussed, but she also had a left hip impingement, which did allow some movements to be painful and some movements to be not so good. So we did have to be careful on what kind of exercises we did give her. And a lot of the times her upper trapezius muscles would overwork even if we gave her a leg exercise. So we had to be careful when we were giving her exercises and make sure we cater them and modify them accordingly. She wasn't able to tolerate in the beginning the treadmill test that we usually do for a VO2 submax test for our physical therapy outcomes. So that we needed to work on her cardio strengthening and strengthening as well as a cardio conditioning aspect. The main thing is she couldn't bend. She had a lot of tension, a lot of guarding, so that was our focus, was to try to get her body to move with less fear. She was very fearful of moving in different ways. Some of the treatments, as you can see here, I'm not going to go through all of them, but again, we did a lot of gentle stretching, modified strengthening and stretching, listening to her body, teaching her pain control modalities such as heat, ice, self-management using different tools for self-massage, and also looking at her goals. You know, not just the PT goals, but also the patient's functional goals. You know, she wanted to walk, she wanted to do stairs, she wanted to exercise without increasing her pain. Manual therapy was given to Cathie, but at a minimal basis. She did do well with myofascial release, trigger point release techniques. I also worked with her with some joint mobilization to her pelvis and low back. This picture depicts one of our favorite tools that a lot of patients love to try out. We have a couple of these in the office called the TheraCane. So not only do we show people using their own hands, but also a variety of different tools, such as tennis balls and TheraCanes. And it is a goal for all the clients to do a self-massage technique 1 to 2 times a day, as well as using heat and ice. Either one, whatever works for them. But a combination of them every day has been really helpful, and it has been helpful for Cathie as well. One of my integrative medicine approaches that I thought was very helpful was a technique called core integration, which is now called core movement integration. One of my instructors and mentors is here in the audience, Arthur Medor. I'm sure some of you know him very well, so thank you for coming, Arthur. And so if it wasn't for him, I wouldn't be able to do this amazing technique and also use it on myself. So Cathie, some of her treatments were using the core integration, which is actually based upon Feldenkrais principles. It's using 6 core movement patterns that were created by a gentleman named Joseph de la Grade. So with this movement pattern treatment, she was able to gain improvements in her posture, spinal and hip flexion and rotation for tasks such as reaching, bending, and doing Tai Chi easier, So when she came in, she would just reach for something, and then her upper traps and everything would tighten. But using this technique, she was able to just connect and try to do a nice fluid movement. And so the pain and the tension and the fear actually decreased using this core integration approach. Combined with the OT, she really got to be able to move better. So if it wasn't just PT alone wouldn't have been able to get her to the point where she was, and OT will be discussed later on, but using the OT relaxation and biofeedback training in combination with my core integration really made a huge difference in the way that Cathie was able to move and function. There is not a lot of literature out there on the core integration, but I just wanted to point out just a couple of different pieces that are out there. One area that was focused on was at the Institute of Postural Analysis in Florence, Italy, and they found that the core integration postulates that there's a relationship between posture, functional movement patterns, and pain. And so you can actually prevent pain by actually trying to combine movement patterns versus doing specific tense, guarded movements. There is also a study at the Worcester Polytechnic Institute in March 2008, where they measured spinal rotation using a particular device that they created themselves, and they attached it to the thoracic spine. So people that walked on a treadmill were compared with people that used Feldenkrais principles and the core integration techniques versus people that never had any experience at all. And they actually found a significant difference in the speed, the velocity, the ease of movement, and the translation and rotation of the thoracic spine. There is also an article in the Journal of Massage and Bodywork by Joseph Delagrade, and it actually is an important article because it talks about not only the clients being able to prevent and actually help the level of pain and tension that they're having, but also the people working on the client and how the movement patterns of you working on the client as well as the client both benefit from using the movement patterns. And so that the postural pain syndromes can be caused by the way you move versus, just trying to do something specifically, but coordinating your whole body instead of just using one specific movement. So these are some values that before and after, you can see there is a big difference between the cervical spine that Cathie came in and the thoracic lumbar spine. So she did do a lot more bending in all areas, and she was able to pick up items lower than her waist and lower than her knee compared to when she first came in, where I had to actually help her take her purse and her items off of the floor and off of the chair when she first came to see me. And there's some other values for shoulder and hip and cardio and strengthening. So she started out with only being able to do 4 to 5 repetitions of strengthening, and then she ended with 15 repetitions. Walking, I know it doesn't look like there's a lot of difference, but the 5 minutes that has increased, it actually improved and actually the ease of movement, the speed, the step length, the symmetry, the heel strike. So walking improved with a lot of different aspects. It was a little bit hard for her to increase walking because of the left hip pain. That was her main limitation, but her movement patterns increased dramatically. Okay, so I'm going to hand it over to Eve for the occupational therapy. Aren't they cute? We found some.
You guys can see that my biggest challenge as an OT, the first thing I need to do is help people know what the heck it is that I do. Unlike Jen, for PT, many patients haven't had occupational therapy before, but I've heard things like, wait a minute, honey, I don't need to see you. I'm 75. You think I'm going to go back to work? So I start off explaining that as an occupational therapist, what I do is help people do everything they need to do in their life and find a way to do it that's comfortable for them. And the first question that I ask somebody during my eval, and I say this is the most important question because it really is what are your goals? What do you want to get out of being here? Now, Cathie was much more articulate than many of our patients who will immediately say to get rid of pain. She really knew that she needed to understand what was happening in her body. and know what to do to help avoid herself from continuing to flare up, to be able to get back to these things that she loved. When I first met with her, she was having a lot of difficulty and pain, even with basic self-care tasks. She was still working part-time from home, which involved a lot of computer work, and that was difficult for her. Her job also involved long drives to the Berkshires, which she really wasn't able to do at that time. In order to be able to work, she had stopped her volunteering, she had cut back on her housework. She was really having increased pain doing just about everything. Her 18-pound dog was a challenge, so she had to cut back on walking the dog because that was painful. And she was having difficulty just getting up and down from a chair, in and out of bed. And the biggest thing that was most notable, as Jen mentioned, was Cathie was very afraid to move. She didn't know what was going to set it off. So as you can see from this slide, what the OTs do in the program is huge. It's far more than I have time to cover everything here. But we go over a lot of pain coping skills. We worked on how to be assertive with family and to set limits, how to pace and take breaks before your body was wiped out. We did ergonomics, both in her car setup and in her work setup. And I'm going to go through a little bit more of some of the more integrative techniques that we used. So biofeedback basically is using any kind of instrumentation to show us what's going on in the body for something that we normally wouldn't be aware of. Now, many insurance companies don't pay for biofeedback because they think that it's synonymous with relaxation training. And although that is a huge part of biofeedback, what the OTs at Spaulding do is use it for neuromuscular rehab. So we're doing movement retraining. We're teaching people how to move without over-tightening the body. So Cathie worked on how to be able to reach without hiking her shoulders, how to be able to walk and let her back move with the walking rather than holding it locked. Being able to see on the screen and really train your body is the biggest thing to really show I do have control over these muscles that I didn't think that I did. Cathie had a lot of experience with relaxation training, but her techniques at that moment weren't working for her. And one of the things we really talk about is there is no one right fit. There are many different types of relaxation. So we expose people to many different ones to choose the best one for them. And one of those was Tai Chi. This started initially to be one of Cathie's challenges. When she first was doing the Tai Chi, it was really increasing her discomfort. And we worked on modifying how to do the movement patterns till she was able to do it more comfortably. The other thing we do is we immediately take it and apply it to function. So that basic rocking movement from the Tai Chi was then reaching into the cabinet, bending down to pick things up, how to, again, make that movement fluid and comfortable. And earlier I showed you our outcome slide. So we used the Canadian Occupational Performance Measure. This is a measure that's client-centered. So Cathie picked the 5 most important goals for her. And in the beginning, she rates them on how is she able to do on a 1 to 10 scale. 1 meaning not at all, 10 meaning extremely well. And how satisfied was she with her ability to do them on a 1 to 10 scale. Initially, as you can see here, she was having a rough time, 2.2 and 1.6 out of 10. At the end, her performance was 7.2 and 7.3, which is a 5-point change. This has been researched and validated for chronic pain, and a 2-point change is a significant change. In addition to the numbers, well, actually, these are more numbers. You can see here that the pain score didn't change a lot, and that's often common for our folks. But what did change was a huge variety of coping skills and really getting back to living and enjoying her life, walking the dog, volunteering, cooking more, sleeping more, and sleeping more comfortably. But rather than hearing me talk about it, the best person to talk about it is Cathie herself.
Hi, I'm way better at Q&A, but just a couple things I wanted to share. Yesterday I went to my rheumatologist who had been working with and diagnosed me several years ago. And he is really great at what he does, and he's very Western. And most of our appointments, we sit down and we negotiate. It's like he really would like me to be on more medicine, this, that, and the other. Yesterday he reviewed my labs after about 6 months from starting the program, and it made my day. He was smiling. He's like, "What are you doing?" And the lab work had improved. There was, like, for example, ferritin is a big part of what I've been dealing with, and I had to go to a hematologist and specialist. They were considering IV because we couldn't get my iron levels up. And yesterday he was like, "These are normal." For 3 years I had been trying, and there was vitamin D, there were other markers. So I think one thing that's been really eye-opening for me, and I knew this, but I relearned it, was that it's cumulative. It's physical therapy, it's stress reduction, it's definitely learning how to do things different, it's communicating differently. It's a lot of things that help a little bit. In my fibromyalgia support group, we constantly look at each other like we would love a miracle. We would love to take one pill and everything be better. But for me, in this program, it's been a lot of little things. A little thing could be getting a new bed that, supports me getting in and out of bed and sleeping better. It could be a diet, it could be stress. It's like a lot of little things. I would say also that for me, there was two main things that were huge. I mean, there was a million main things that were huge, but in this program, where I was in my life right now, I was able to get real information. And so many people go to doctors, and like I have a physiatrist who is really great too. He's not as, Eastern, but he will only treat one body part at a time. So he's like, let's fix your hip, and then we'll talk about your back, and then we'll talk about your shoulder. So here I was able to talk, and they all talked to each other, and I got real information. And so going into this with so much fear, the physiatrist, I sat with Eve, and she asked the physiatrist, and he said, "You really shouldn't bend your leg more than halfway with an impinged hip. Other than that, go for it." That was huge for me because I was scared of everything. The other part that was huge for me was I really love the energy hygiene. Something about that really clicked for me, and it also helped me get back to meditation and other things differently. Just that whole walking through a day with chronic pain and having fear about everything, there's this whole conversation that's causing so much stress that I'm letting go of. I'm accepting it, and that to me was energy hygiene. It's like, do I want to have this argument with a loved one? No, because I can feel the tension in my body. So how am I going to do it different? Do I want to push through this drive and not stop at a rest stop? I would rather get to my destination. I think I'm going to accept the fact that it's better if I get out and walk in ice. So anyway, I'm happy to do the Q&A part, but that's just what I wanted to share.
Wow, and we had no idea that her ferritin levels had improved. We're just going to give you an overview now with a discussant, Dr. Ariana Vora, who's a physiatrist in the Spaulding and Mass General system, and then we'll open it up to the Q&A again. Thank you, Ariana.
Thank you, Rick. Thank you, everyone. What an incredible program, huh? I mean, this functional restoration program is just amazing. I'm going to try to give you some perspective from the physiatry standpoint, another part of the rehab team, and talk a little about integrative rehabilitation as it connects to what you've heard today. No disclosures. So there are many theories, and there's a great deal of speculation about the fibromyalgia syndrome, as it's called, or chronic widespread pain. There's the idea of, many people feel that there's a chronic exposure to painful stimuli, or it could be emotional, physical, or cumulative, over time. And there's an autoimmune theory, there are theories about low hormones, there are so many theories about this, we just really don't know, but I think many people feel that there's an idea of cumulative trauma, micro and macro trauma over time, which could be physical, emotional, mental. And usually once there is this develops, this kind of widespread pain, we often see deconditioning, guarding, reduced functional performance, and difficulties with sleep and mood, and quality of life just goes down. My job as a physician, as a physiatrist, is in the rehab team is we try to provide person-centered care and do a very comprehensive history. And part of my job with respect to the functional restoration program or similar programs is to give her that go. Is it a safe pain or not? And it's kind of my responsibility to figure that out. So as a physiatrist, I'm going to be doing a very thorough history, a thorough musculoskeletal examination. We're going to be talking about quality of life, which researchers have a hard time defining in medicine, but it's actually very simple. People know what they want. They really just ask. And we talk about personal goals. We try to individually tailor the treatment because everyone has different goals and different bodies, and foster independence while also guiding treatment. And that's a big part of this program too. And we want to coordinate and facilitate all the different players, and there are many players at Spaulding and Medford, and make sure that we incorporate the mind-body piece, the mental health piece, the energy hygiene piece in many cases, and the PT and OT. So what is the pain generator? So in this particular situation, I wasn't Cathys' physician, but having looked at your history, looking at the headache, was it a true migraine? Is there a cervicogenic component to the headache? We have to look at the neck and see. Overactive upper traps, usually what does that mean? Musculoskeletal, there's usually a lack of activation of the lower lats, the core. There could be tight pecs, but also there could be just stress, and emotional stress tends to, people do things to their bodies when you're stressed, and they start to be pretty active. The hip pain, people say impingement. True impingement is congenital and brought out usually by muscle imbalance. And so it was probably always there, so why is it hurting now? And usually there's a muscle imbalance that we have to find in our exam and talk with Jen about, and everybody would know, then this is the issue here. We need to work on the muscle imbalance, and in order to do that, we have to move, and so in order to do that, we've got to deal with the emotions around that. So it's very interdisciplinary. It has to be. I don't think it can be multidisciplinary nearly as effective as interdisciplinary, like a team approach like this, and looking for contraction. And the hip pain, was it that? Was it impingement? Was it OA? X-rays are not well correlated with symptoms in this case. Are the nerves healthy? The superior colonial nerves are often missed. Sometimes they're a pain generator. So I'm trying to find the pain generator and just try to discern whether, what's going to be the best focused approach. And always questioning medications. Was the triptan necessary? Tizanidine can be sedating, so some people try to give that, and maybe this will help you, and on the other hand, people can be sedated by it. Ibuprofen, as we know, is not benign. What are we treating with this ibuprofen? We want to avoid the long-term use of opiates and benzodiazepines if possible, and check her vitamin D level because there may be a correlation with low D and musculoskeletal pain. And then a functional assessment is part of the rehab approach. As you've heard, how are you functioning at home, at work, at family, social life, recreation? What's the baseline function, and what are her short-term and long-term goals? And in fibromyalgia, the so-called fibromyalgia syndrome or chronic generalized pain, generally there are early stressors around the time of symptom onset, and it's often a persistent severe pain, which could be any level of pain. I often see a history of sexual abuse in many of my patients who have chronic widespread pain. You have to really ask questions about it and think, how long has this been going on? It's kind of becomes a deep, long-standing physiologic, emotional, mind-body issue. And we look at ongoing stressors. And then in terms of, what goes in the body, I won't go into all of this, but basically, we want to reduce caffeine, reduce sugar, and she did a great job with her diet. And, it's just really really admirable, what you've done with your diet. And there are things that we think might be inflammatory, and we don't know that well, but she's taken many steps to do that. And, sleep and pain, there are many studies about sleep disruption and chronic pain. So the sleep hygiene and the mind-body therapies, and just the simple idea that you rest when you're tired. In many cases, you just need to rest your mind and your body. In a proper way. My integrative practice is grounded in Ayurvedic medicine. That's one of my primary trainings in integrative medicine. And in Ayurveda, the definition of health is basically, it's up here in Sanskrit, but basically it means that all the parts of your body are going to be balanced. All the parts of what makes our body work, including our enzymes, our digestive fire, our elimination, what we take in and what take out, our mind and our sensory organs. And what's interesting is the way I see it and is based in Ayurveda, is that the body is a manifestation of the mind. So what you do with the mind is so core, and it affects the body. If you don't have all these things, you're not really healthy in Ayurveda. So it's a lot, and it's interdisciplinary, and it's multidimensional. According to Ayurveda, fear and pain are very much connected, and sensitivity, and this was very much the case in this story. So we want to, and they have very wisely addressed the fear component, the right living component, and just taking the self-care component, and energy hygiene, conserving energy and having quiet time. And then there's this idea of sattva in Ayurveda. There's spiritual connection or kindness or mindfulness, or however a person can experience that part. It's part of health. And finally, when we're looking at an integrative rehab approach to chronic pain, as you've heard, I'm just going to echo what we've heard from these amazing speakers, is that, just to highlight, we're looking at person-determined quality of life. We're putting meaning of life goals central, and we're looking at her daily routine, her nutrition, her movement, and we're looking at symptom management to some extent, but we're also looking at empowerment, not just passive, but active approaches to the rehab. The Theracane is an example, and I have people say, well, you can do a lot of this yourself, and then there's the musculoskeletal treatment that Jen discussed, and you can see that she made amazing gains physically, and as well as functionally with the biofeedback. And I think the thoughts to behavior to pain is just so central across multiple models, and they did this so beautifully at Spaulding and Medford. And I think the rebalancing and the way that she absorbed emotions and the way that we're developing sort of an immune system around that is really admirable. So this is the functional restoration program. It's an incredible way to look at all of this with a great team, which is so rare. So I'm really, it's wonderful to hear everything that you all shared, and to be here and listen to this. Thank you.
Thank you. I just have one question for you, Ariana, before we go into the Q&A. Will you come work with us at Medford? Before opening up the Q&A, I just want to give a shout out to our medical acupuncturist, Bridget Chin, who did not work with Cathy, but works with so many of our patients at Medford and some of the other affiliated sites as well over there. Questions, comments? Do you want to?
Yeah, I'll lead it anyway.
Yeah, okay, great.
So first, before we start the Q&A, I just wanted to just give a round of applause for the team, and thank you, Cathy, for being presenting, willing to share your story with us. So questions. This has been a fantastic presentation. So we're left speechless. Yeah. No.
First of all, I was really impressed with the integration and how intense the people work with, the volume of it, frequency, and so forth, which seemed to be an important part of this. My question, just as a practical matter, because I can see referring people with this situation who need that kind of care, how is the insurance? How does that cover it? What can a patient expect to pay for this?
So insurance covers, we take up almost every insurance, and it is all covered, billed through MD, PT, OT, and behavioral health for the main programs. That includes everything that we've talked about today. If the person additionally is getting acupuncture with Dr. Chin, some insurances cover that. And otherwise, we have self-pay rates for that. The same thing with our massage therapist. But the rest of the program is covered through insurances.
That was a great presentation. Thank you. Fantastic program. I have a very practical question as well. What does the communication between your team members look like? Is it happen through electronic communication? Do you guys all sit together weekly? How does this integration happen besides all of you knowing each other's expertise?
Well, it happens on several different levels. Electronic is probably the least important of the communication modes. We have regular patient care conferences where each of the people in the program is reviewed by the collective team, and there's a literal back and forth. It's entered into the medical record, and because LMR is available throughout the network, other practitioners, such as yourself, can read the weekly PCC notes. But most important, we're under the same roof, and actually the pain team members happen to have their offices all in the same wing. So we can't help but bump into each other. It's impossible to avoid each other. We actually enjoy bumping into each other. So it's a lot of curbside consults and just schmoozing type of thing. And so the physical setup really encourages that.
Yes, on that same question of mechanics, administratively, say something about case management. There was a list of medical case management up there, and I'm curious how. At least I saw it on one of the slides. So how does that work? And does each patient have it? How central is it, or not central?
So every patient has a core team of therapists that are their primary therapists. So they're responsible for making sure that everything is coordinated outside of the center and that the external physicians get all the information that they need, the insurance companies get the information that they need. But also a big part of it is really starting from day one with the patient and really talking about what life is going to look like after the program and helping them work on discharge planning. So that's where a large piece. So it's the central team that does it.
A little unusual in that the physician, the pain physiatrist, played a relatively minor role in her treatment. Oftentimes, the physician will be the coordinator of, the referring docs and the primary care docs and the different specialists. In this case, his role wasn't that important. The interventions had been done, and it was more, okay, let's get the PT and OT and the rehab done. So it can, different models for different situations.
Ariana, can you talk a little bit about some of the challenges in this type of program from a physician perspective in a larger sort of complex medical system?
Yes, there are many challenges. I think one of the big challenges is that I and most of us don't have the extraordinary setup and the talent of this whole team in-house. So when I see someone who has, I won't even say just widespread chronic pain, but any kind of chronic pain, and the goal is, I want my pain to go away. There's a long way to go. And I don't have much of this in-house, so I think for most of us, it's trying to get that spark in the patient that it is very difficult, that it's not just about the pain, and that some kinds of pain, I'm not going to be able to just reduce the symptoms. So I think it's a question of time and communication, and having that structure, which I think most of us don't have. I just wish we could all work at Medford. But it's very challenging, and I think we end up spending a lot more time, longer time, and then at the next visit we do a little bit more and a little bit more, and maybe I'll have a breakthrough and they'll agree to do some mind-body work with a psychologist, and that's a big deal when that happens. And I have to say that, Cathys is an amazing individual and had a lot of insight. Not everyone has that kind of insight right away. So I think For me, the challenge is my limited time, because I'm spending a lot of time on the physical part, which may not be as fun. I have to do all the exam and go through all the records and go through all the radiology reports and ensure that I can actually say to this person, this is a safe pain. You can do this, in good conscience, and I'm right about that, as right as I can be, as I can know, as much as I can make a judgment call. So it's very slow oftentimes, but I think it's just making that time to listen, which does take time, and find that window, and the person shows me the way, But it's challenging, and I wish we all had a place where we could all meet and talk to the other people on the team.
It is time intensive to do true deeper healing, and the system doesn't work in our favor. We originally were set up as an inpatient residential 4-week pain program, and it was, as you can imagine, very intensive, because if you're living and breathing it for 4 weeks, you can make huge changes. But gradually insurers stopped covering it, even though, as Eve mentioned, the data is there that they would save money in the long term. But they're not interested in the long term, they're interested in quarterly expenditures. So the program's been pruned back and back and back based on what's covered. Eve has done some very creative billing, shall we say, to get coverage for some of these treatments. A lot of it, such as acupuncture, will often depend on patients having resources or institutions having funding to subsidize some of these treatments, and that's one of the directions that we're moving in Spaulding as well. But things take time, and you can't just cookie cutter everything.
And I can also speak a little bit. I know that some of our physicians, some of the challenges have been, helping the patient shift from the model of, I'm here, give me medicine or give me an intervention that's going to take the pain away. And we are a strictly non-pharmacological program, so our physicians make consults and recommendations regarding pain medication management, but we don't actually prescribe. And I know one of the things that's helpful for them is, for many patients, that's the only tool they've had. So they don't really know what else is even available. So to be able to say, no, I'm sorry, I'm not going to prescribe this, and these are the reasons why it's not good for this diagnosis, but I am going to give you a place where you can get these other options, at least helps that they're not doing it in isolation.
Cathy, if you can just comment from your perspective, what has been sort of the greatest gift of this program, and also one of the greatest barriers to accessing the program?
There's way too many gifts, but the one that's on my mind based on your questions, everything's under one roof. And so you asked the insurance thing, people say they went to a PT and it didn't help, and they maybe want to do nutrition. The patient has to find all of this, and they're not always resonating with people. So the fact that everything was under one roof, and the 4 hours we're programming, and maybe exercise or Tai Chi, but every single week I had one-on-one time with everyone, one-on-one time, and this was all covered in the insurance. So that's a huge gift. And I really don't remember the second part of the question.
Any barrier that you, as you went through this program, that you thought would be important to note?
I can't think of a barrier. I just think it was setting realistic expectations. I can hear Jen's voice in my head still saying, trust me. And it took about 6 months, and a light bulb went off. I was like, that's what she meant. I am going to feel stronger. So, maybe the barrier was myself, in the beginning.
Okay. So one final comment. I just
want to say, she's not a typical patient. To be honest, they don't all come out of the program as eloquent and transformed as Cathy, but don't people choose their favorite patients to present? Go ahead, Bridget, sorry.
Oh, no, I just wanted to comment the education aspect of, teaching. The education aspect of teaching the patient that, your level of VAS, which is a terrible scale anyway, may not go down. And that the goal is not to get rid of your pain. The goal is to help you heal functionally and improve your quality of life. And that's really vital. And it's very hard to do that in a short amount of time. And unfortunately, the acupuncture didn't work for you. There have been many studies that say, if acupuncture doesn't work for fibromyalgia, But a lot of those meta-analyses are based upon really, really poor studies. There's confusing things about the diagnosis of fibromyalgia, because it's like, this, last resort type of diagnosis, and now there's more receptor research that some patients may have a receptor defect that may make them susceptible to chronic pain syndromes. And also there's now new evidence of, these patients may have an Ehlers-Danlos syndrome based on some genetic testing for only some syndromes of Ehlers-Danlos, so different types. So there's a lot of things that are going on with chronic pain. And I think the most important thing is to educate the patient that, we're not going to get rid of your chronic pain. It's going to be there, but it's going to be at a level where you can function better in life.
So on that note, we wanted to invite everyone to continue this discussion just across the hall and to the right. We have coffee hour and refreshments and snacks and fruit for everyone. Once again, big round of applause for the Spaulding team. Thank you so much, and thank you, Cathy, again. Just a quick announcement. Our next presentation will be Tuesday, December 1st, here, 8 to 9, and we will have presentation on case by the Osher Center and around Parkinson's disease and an integrative approach in management of Parkinson's disease. We have, as I mentioned, this Thursday, we have Integrative Medicine Research Grand Rounds seminar led by Peter Wayne, and it's featuring a presentation on acupuncture and its role in postmenopausal symptoms. And then next month, again, Research Grand Round seminar will be, Peter, remind me, I'm sorry, I forgot.
Howie Sessa speaking on how super are superfoods.
That's right, superfoods. So, nutrition research. So again, first Thursday in December from 4 to 5 here at the Brigham. And all of this is available on the oshercenter.org website. Please make sure you sign up if you haven't signed up, if you're not receiving the the periodic announcements. And am I missing any other announcements? Good. Okay, great. Okay, please convene across the hall. Thank you again.